Good afternoon, everyone. Today, it's my great pleasure to present to you this pilot collaboration between UNC Rheumatology and Piedmont Health Services. As many of you know, the literature shows that in the U.S. rural populations face unique barriers to healthcare access and have, for this reason, worse healthcare outcomes. Rural minority populations are disproportionately affected, and rural minority populations with rheumatological illnesses face healthcare access barriers as well, and these barriers are anticipated to progress given the rheumatology workforce shortage. Therefore, telemedicine is more and more being adopted to help rural populations access rheumatology care in the meantime. North Carolina, it's a highly rural state with a growing rural minority population. Piedmont Health is a federally funded nonprofit organization with 12 community clinics throughout the state of North Carolina that serves mostly rural and minority patient base that has well-known unmet rheumatology access needs. So our project it's a pilot project that we just started this year with the funding of the Arthritis Foundation, has two major aims or goals. One is to improve the access to rheumatology specialty care. And the second major goal is to empower the community providers to manage rheumatic disorders. An added goal of this is to have our fellows in training to participate in care of patients from the minority patients in rural areas. So how do we plan to do this? Well, we plan to do it through the use of shared telemedicine model and through rheumatology education program for the community providers. So this shared telemedicine model depends on the recruitment or triaging of patients into this telemedicine clinic. We recruit patients who have had prior rheumatological diagnosis and who lost follow-up with rheumatology specialty care at UNC mostly, and that have continued to be seen at the Piedmont Health clinics. The other set of patients we recruit are patients that can be new or established patients at Piedmont Health who present with new rheumatic symptoms and who have the usual barriers of the transportation problems, financial barriers, and others. So we implemented monthly clinic sessions that are conducted via shared visits between an on-site Piedmont Health provider who is at the same time with the patient in the exam room, and they're connected virtually to an off-site rheumatology team consistent of the attending and a fellow. The PHS provider has been trained to perform and gather the objective data and perform the physical exam with additional guidance during the visit through video by the rheumatology team. And the rheumatology team obtains the history and it provides the final recommendations at the end of the visit. The other portion of our project is the didactic and educational portion for the community providers. And these are also monthly didactic sessions that are offered not only to the 2 participating clinics in the pilot, but to all the providers in Piedmont Health. Usually, this is done at lunchtime during our shared rheumatology clinic once a month. The topics that we have been covering are high-yield rheumatology topics geared to the community providers, and they have ranged from evaluating, for example, pain from a rheumatology perspective, using and interpreting serologies, evaluating and managing the most common rheumatic disorders, and also talks on methotrexate and its management and complications. After each session, a 5-point Likert survey is given to the audience to collect didactic satisfaction data. So additionally, we also used surveys to collect self-reported demographic data from the patients. And between January and September 2022, we have documented 48 patient encounters, and the surveys were completed. And these surveys so far show that most patients are female. Most are of Hispanic ethnicity and they speak Spanish. The majority of these patients are uninsured and have a high school degree. And the majority live between 30 and 60 minutes away from Chapel Hill, where our clinic is. I must add, and it's not showed here, that most of these appointments, if not all of them, were made within a month of the initial referral. Additional data that we collected from the patients, as many of these patients had already an established diagnosis. As you can see, the majority had rheumatoid arthritis in the left panel, but there was many other rheumatological diagnoses in the patient population. And many of these patients were already on DMARDs, as you can see in the panel on the right side. And as you can see as well, is that many patients did not respond to this particular question, which reflects some of the limitations we have experienced implementing this pilot, that patients don't always are able to complete appropriately the surveys. And it's something that we're going to continue to work to optimize. As mentioned before, we use 5-point Likert type surveys to evaluate the patient satisfaction with the visits, as well as the demographics. And we also surveyed the participant Piedmont Health and UNC providers. We added a component of measuring for the Piedmont Health the confidence in caring for patients with rheumatic diseases. And these are examples of the surveys that we use. And I must also clarify that we have versions in Spanish as well. These are more examples of the ones we mentioned before, the post-didactic surveys that are completed after each didactic session. So what have we found so far? So far, patients' reported scores are very high. The majority of patients valued, as you can see in the middle panel, the time they save not having to come to UNC to be evaluated. The majority of patients also consider that the virtual visits are as good as the in-person visits. And also the majority think that they would like to continue to have this platform for their follow-up visits. I also want to clarify that we give the option to the patients to be seen in person if they're not satisfied with the virtual visits. Additionally, the post-visit provider satisfaction scores are also high, as depicted in this graph. And the post-didactic scores have also consistently been high. So in conclusion, so far we have found that this project, pilot project, is a unique partnership in North Carolina, that, or at least that I know of, that seems to improve access to rheumatology care for a rural population who reports high satisfaction scores. It also seems to allow timely specialty care and alleviates barriers related to transportation and insurance coverage, and also broadband access. The focused didactic sessions and shared care visits seem to be empowering the rural community providers to manage more of the rheumatic diseases. And finally, I would say that right now we're only operating with or collaborating with 2 sites of the 12 sites that Piedmont Health has in North Carolina. But if the data continue to be encouraging, we envision to expand the program to other areas. And in terms of future directions, we plan to continue to refine and optimize the triaging process within Piedmont Health, as well as the survey data collection. We plan to have dedicated MAs at the end of each visit in Piedmont Health to assist patients in completing the surveys. We're also going to use electronic tablets for patients and providers to enter data to a database at UNC in Qualtrics. And for the second phase of the project, we plan to use more in-depth mixed methodology using methods more quantitative, and also continue some of the qualitative methods for collecting data, including structured interviews with patients and also Piedmont Health providers, and looking at the data in the Piedmont Health electronic medical records that pertain to transportation issues, time to initial visit from the time of the referral, the cost of the visits, the time to first diagnosis of the rheumatological entities, time to starting DMARD or biologics, optimization of the management of RA with training the Piedmont Health providers to use validated tools like the CDI for treat to target strategies. We're going to look at adherence of patients to medications and visits. And we're going to get the input from the community providers in terms of comfort in managing rheumatic diseases and the ease for referral and having the patients seen. this is I'm, I'm going to end there. I'm going to want to thank the Arthritis Foundation for the grant support, and Piedmont Health for the wonderful collaboration. I want to thank Julie Norfleet and Shruti Saxena Beam from the Thurston Arthritis Research Center for their help with the project, and all the physicians that participated, including Leah Bettner, our rheumatology fellow, Dr. Rumi Shishawa, who's a PI of the project, and Dr. Eli Tiller and John Dalton, who are the Piedmont Health physicians, as well as all the rheumatology faculty and fellows who help with the didactic sessions.